All right, let's start off by going over the quiz. And I need somebody to hit the magic microphone and tell me the answer instead of everybody saying it out loud. So whoever thinks they've got it. Why do we interpret lung volumes based on predicted values rather than on actual values? Oh, somebody has to know the answer to this. Who's going to be brave enough to say it out loud? All right.
You have to take into account the factors that affect the lung volume, like age and gender and height, and so you have to establish an accurate baseline in order to make a comparison. You can't compare them all to the same baseline.
Yeah, I don't know that I'd say it's a baseline. I'd say you're establishing a norm. Yeah, and you have to consider all of the absolute factors, physical factors that can impact absolute lung volumes. So that's why we normalize it. What lung volume would we use to continue speaking below resting expiratory level? You're a quiet group today. This is scary. Yes?
The expiratory reserve volume.
Expiratory reserve volume. The worst possible answer, just so you know in case of the extremes, the worst answer you could do is residual volume, because you should always know that you cannot speak on residual volume. Even though people talk about talking on residual air. They're lay people, obviously, not sophisticated speech scientists like we're going to be. All right, what's the physiological basis for residual volume? What causes it to exist? Go ahead.
Because they're connected to the thorax, and so they're always kind of stretched out.
They're as in the lungs are connected to the thorax? Yeah, and what connects them? Pleural linkage. So if you say something about the pleural linkage and the lungs have to move with the thorax and that keeps them from deflating completely, that would be great. Two characteristics of someone you would expect to have a very large absolute vital capacity, like the actual measure. What's this person going to be like? Yeah. Go ahead. Tall swimmer. Tall swimmer is good. You've got the height going for you. We know that tall people tend to have a larger vital capacity. We know that swimmers do because they're working against the resistance of the water. Yeah.
Someone with a large rib cage.
Large rib cage would do it. Yep. Mm-hmm. So you get to push the button forward. That's okay.
A classical singer with a large rib cage. Is that
classical singer with a large rib cage? Yeah, that would work too. So you can put some professional things in here.
A male.
A male. Yep. And my classic answer, of course, is Yao Ming. You know, if you're a guy like him, you're going to have a really big vital capacity. What is the manometer used to calibrate? Go ahead.
a pressure transducer?
Yep, a pressure transducer. Notice I didn't make you spell pneumotachograph. But what does it measure? Airflow. Yeah, when you can do all together. So you're speaking below resting expiratory level. In what direction are the passive relaxation forces? Yep, go ahead.
Towards inspiration?
Yep, towards inspiration or in the inspiratory direction. You're an opera singer who's just breathed in maximally to sing a very long phrase. What forces are needed to counteract the passive relaxation forces? Go ahead.
The inspiratory muscles.
Inspiratory muscles. Yep, good. As you're inhaling, describe the relative pressure of the lungs compared to the atmosphere. Got a 50-50 chance on this one, right? So what's the relative? Go ahead.
The air pressure in the lungs is lower than the air pressure outside.
Yep, air pressure in the lungs is negative or less or lower than the air pressure in the atmosphere. How would you interpret a person's vital capacity if it's 115% of predicted? Yeah.
I thought 100% was the maximal exhalation. Can you go to 115%?
You can go to 115. I hope that's not what you put. So what if you see somebody who's got 115% predicted vital capacity, what does that tell you?
I put that they might have an enlarged expiratory reserve volume for some reason. Like we said, maybe they're an elite athlete or they're really
so
tall.
Something about who they are is making them have one volume bigger than most people's. That would work.
I said that the
vital capacity, it was higher than what was expected for their like age, gender, height. There, it was higher for what was expected for them.
But how would you interpret it? What would that higher mean to you?
I just put maybe they were physically fit, exceptionally physically
probably
fit.
really well. Yeah, they're fit, well conditioned. Yeah.
I put that they're probably either trained, through exercise or something, but that you could also pretty much guess that they may not be a couch potato, cigarette smoking, lazy person.
So you'd assume they're not a smoking couch potato. That's a bad image, isn't it? Little potato on your couch. Okay. Any questions or comments on those concepts? Yeah.
With the question on the answers, the inspiratory muscles going up.
I have to see what the question was.
It's the first one on the second page, I think.
The opera singer?
Yeah.
Okay.
So it says be specific. So I talked about, I never said inspiratory, but I talked about the external intercostal muscles in the rib cage staying open, keeping the lungs open. Yeah, I think I said contracted. And then the diaphragm staying contracted and flat.
Those are the inspiratory muscles, so that's perfect. Yeah, so anything that implies you're counteracting passive expiratory forces with active inspiratory muscle forces. Now, one thing I'd like to caution you about is if you're kind of vague on some of these, don't just blow it off at this point, because remember the final is cumulative. So if you get lost now, it's going to be even uglier when this information is cold by the time you're studying for the final. So try to get all the concepts as we go along. Sure. When you've breathed in up to as much as you possibly can, when you would just relax from there, all of the passive forces are in the expiratory direction. But that singer does not want to waste all of the air. So the singer's job is to counteract those expiratory relaxation forces. And to do that, they have to use inspiratory muscle activity. And that's something that singers are taught constantly. They have all kinds of names for it, all kinds of strategies to do that. But really all you're doing is counteracting the tendency to go down really quickly to resting expiratory level.
Is that the same thing as checking action?
You bet. It's exactly the same thing as checking action. In fact, I was trying to think of that word and I couldn't, so thank you. Yeah. So you're checking the descent of the rib cage. Yeah. Are you doing the microphone thing? Sorry.
The vital capacity is the maximum amount of air that's exchanged, right? And your example was if you breathe in 300 cc's and you breathe out 300 cc's, what's exchanged is really 300 cc's. So at first I was I saw, oh, it's an average, but it really isn't an average. So because if you breathe in 200 and exhale 100, you're only exchanging 100?
Yeah.
Okay.
So you need to just assume that you inhale and exhale the same amount. But in vital capacity, if you're actually physically measuring that, now software just gives you the number. You're doing it on one limb. Yeah, it's peak to peak.
Okay.
So you sort of ignore the inspiratory part and you go from peak inspiration to peak expiration. Yeah, some of these concepts were easier when you had to actually measure them by hand. But now software gives it to you. So some magic numbers appear. But before, when you physically looked at a kymograph, that chart recorder, and you saw things go up and down, and you knew where to measure it, it was a little bit more concrete. Other questions? Yeah.
For the opera singer question, I think I put something like after the expiratory reserve, what's left is the residual volume, and they're using the residual volume to keep that air going. I mean, that's what, I don't know if I wrote it down wrong in my notes, but...
Well, residual volume, though, is going to get you in trouble because we cannot access it, no matter what. So at the peak inspiration, there's nothing beyond that. And at peak expiration, there's no more air that we can use. So residual volume gets you in trouble anytime you think of it other than just the air that's left in your lungs. Oh, I think what maybe you were thinking of, we talked about the fact that highly trained singers have a smaller residual volume. But that doesn't mean that they're using it. It means that their vital capacity has been extended in the expiratory reserve volume direction. Does that make sense? So out of their total lung volume, residual volume is proportionally smaller.
I have in my notes that you can't expire the residual volume because your skeleton prevents you from doing that. Is that accurate, or did I just make that up?
Well, I think it's a little bit better to think of it as the pleural linkage is what prevents you from exhaling residual volume. The skeleton is what limits our vital capacity in general, because we can't, we're constrained by the rib cage being bones. We can't stretch it out. So that's what constrains us in the inspiratory direction. But in terms of residual volume, think about the pleural linkage. Other questions? Okay. What I'd like to do today is talk about measuring speech and singing, talk about how breathing differs between quiet breathing and breathing for speech or singing, and also work on a little experiment just to get an estimate of subglottal pressure. So we know that we talked a little bit earlier about the problems that we have when we want to measure how people breathe when they talk. One of the first things that screws you up is as soon as you put a mask on somebody, which is the very, very best way to capture volumes being exchanged. As soon as you put a mask on somebody, they change the way that they breathe. This is especially true for highly trained singers. If we could flip to the slide, that would be great. It's true for highly trained singers, and it's made it in general hard to measure breathing accurately. So one of the things that people have tried to do is figure out how can we estimate the lung volumes that are being exchanged without having to put a mask on the airway. And we got the ideas from respiratory physiologists, particularly people who study how people breathe when they sleep. So the people who study breathing when you're sleeping really needed a way to look at how air is exchanged without putting a mask on somebody, because it's really hard to imagine falling asleep with a mask. These guys hook up tons of stuff to you anyway. So they needed at least something relatively non-invasive to look at your breathing patterns. And what they developed is called respiratory inductive plethysmography. Yet another phrase I will never ask you to spell. People call this thing a RIP vest for obvious reasons. Its commercial name is Respitrace. And if you ever look at buying one, you look under Respitrace and you will come across this kind of system. And the first thing that I'd like to keep you to keep in mind, anytime we're talking about non-invasive or ways to measure lung volumes that does not involve attachment to your mouth or your airway, is that now you're all of a sudden only getting an estimate. The best that you can do is estimate the air that's being exchanged. There's bound to be some error in the system. Even though you're going to calibrate it, there's going to be some error in the system. And the different techniques of estimating lung volumes have different amounts of error associated with them. So this one is called respiratory inductive plethysmography. If you could switch back to me for just a second here. This is an example of what a RIP vest band looks like. You can see that it's kind of stretchy material. One of these bands would be placed around the rib cage. The other would be placed around the abdomen. First advantage of this, somebody doesn't have to strip to put it on. I've done this lots with clients who have traumatic brain injury. You just wrap it around them. You don't get a lot of error with it being over their clothes. So you've got a nice non-invasive strategy that really doesn't feel like the person. Remember the kid in the video the other day? You know, he was down, he didn't have any t-shirt on. You know, you don't want to have to do that to clients. So the one advantage of this is you can put it over the clothes. The way this works is if you can see inside this stretchy material, there is a strand of wire that's going through it, that's kind of coiled. It looks like a sine wave going up and down inside this material. And when this is attached to the electronics that go with it, there is a current that is passed through that strand of wire. You don't feel it. The person doesn't get zapped. But just picture this attached to equipment that's now sending current going through this wire. Everything electrical that we measure seems to be based on voltage changes, depending what your body is doing. So if I'm breathing in, I'm making this bigger, and I'm stretching it out, and that means that the resistance to the current going through it is changing. When I breathe out, I relax, the current going through it again has a change in resistance, and those voltage changes are what we relate to actual lung volumes. So what we're doing, and there's more magic on top of this because it's really really based on inductance. But just know that the voltage changes as the wire gets stretched and relaxed. Okay? So how are you going to calibrate something like this? You know, you can't just go with, you could for feedback. If you don't care about absolute volumes, I've used this for biofeedback. You can hook the bands up to somebody, have them watch a screen. You can look at what the rib cage is doing when they breathe in. You can look at how their abdomen is moving when they breathe in. You can look at how much air they breathe in. It's great for biofeedback. It's a great way to teach someone to breathe in bigger before they start talking. Okay, it's really straightforward. But if I'm trying to use this to get an estimate of an actual lung volume and trying to figure out how much air a person is really exchanging, then I have to calibrate it. This can be done in a couple of ways. The easiest way is with a 1 liter bag, which looks really strange. I think I might have mentioned it before. It looks like a baggie with a cardboard tube on it. The baggie will hold exactly 1 liter of air. So you have this on a person. You breathe in and out of the 1 liter baggie, and you know how much displacement is how much the lungs, how much the rib cage and abdomen are displaced for 1 liter of air. So then you look, okay, they moved that much, that was only 500 cc's. Oh, they breathed into there, that's twice as much as the calibration move, so they breathed in 2 liters. Do you see how that works? So the key things are that it's an estimate, and you have to calibrate it for it to become even close to a meaningful lung volume. Now there's a couple of advantages of this. This is a fairly long, this is like an extra large, this is a fairly long stretchy piece of elastic. It will go all the way around the person's body. So this will go all the way around my abdomen, it'll go all the way around my rib cage and meet back up here. So what you're getting is an estimate circumferentially. You're getting an estimate going all the way around the rib cage and abdomen. So why does that matter? Why is that a good thing? Go ahead.
Because the lungs don't expand just one way. Like, it's not a plane and it expands out. They're expanding both directions.
Yeah.
They expand in 3D.
They expand in 3D. The displacement that you generate when you're breathing in and out isn't just in the anterior-posterior direction. Now, those of you who are singers probably did this, and I want you all to try it. If you put your hands back here, back where your lowest level of floating ribs are, go ahead and give it a go. Breathe in big and quick. Do you feel movement there? You won't do it breathing quietly. You got to breathe in big and quick. You should feel the ribs back here push against your hands. Singing teachers do that to you all the time. They say you're not breathing enough unless you feel it displacing in like all dimensions. It's a really strange posture to sing from. But that means that if you just used a device that measured displacement in the anterior-posterior dimension, you'd be missing that lateral movement. And that means that your estimate would be even further off. So a circumferential estimate that accounts all of the possible ranges and directions of displacement is going to be more accurate. Okay? So that's why I actually like respiratory inductive plethysmography, aside from the cool name. Questions on how it works?
As far as the calibration goes, what do you do with those numbers? You said, oh, they were...
There are a couple of ways to do it. The old-fashioned way was you would actually measure it on a piece of chart paper, and you would say, okay, 1 liters was 5 millimeters here. And then you would take that 5 millimeters and you would measure everything else relative to that. The way it is now, you plug it into software and it does it for you. So whenever you're trying to figure out volumes, you calibrate the software program that's analyzing it first, and it will say calibration 1 liter equals, and you would put that in. So it's an automated process now. But once you know in voltage and in a chart displacement what 1 liter is equal to, you just apply it across the board. Does that make sense? So if 1 liter was 5 millimeters and I see a breath that's 10 millimeters, I know that was 2 liters.
So does it change for every person?
Yes.
Okay.
Yep. So you have to calibrate before each new person you would test. You always calibrate, because you calibrate even within a day, because certainly in Houston, we know our electricity changes like crazy. We have brownouts, we have lights flickering. Electricity changes. So you have to calibrate right before the person you're actually measuring. Other questions? Yeah.
So the estimate of the lung volume that you get is by the person breathing in and out of the 1 liter bag?
Yeah.
Okay.
Or anything that you did to relate it to a known volume. That's just sort of the easiest way to do it. But there are other ways that they could do it. You could have them breathe into a spirometer and say, okay, stop, that was 1 liter. Now breathe it out. But the 1 liter bag seems to be a nice constrained way to do it. Yeah.
So are we still using percentages to relate across clients like we were in the other one?
No, that's really just for vital capacity. Okay. So when we're looking at speech breathing, we do normalize it, and we normalize it based on the person's vital capacity. So you can do it a couple of ways, but the most common way is to, let's say a person has a 3 liter vital capacity. You would relate, for example, how much they breathed in to the percent of vital capacity that ended up being. So you're right, everything is normalized, but it's normalized according to each person's vital capacity. Other questions on the RIP vest? Okay. The other common indirect way to estimate lung volumes that we saw in the video was using magnetometers. And I just wanted to go over it briefly to be sure that you had the concept of how it was done, because the kid was a little bit distracting. One of the things he did that would totally screw up the measure is when he changed his posture, you'd lose your calibration. People who are measuring this have somebody sit in special chairs that has a little gap in the back for the magnetometers that are in the back. And if you change your slump, you've changed the orientation of the magnetometers, and you can't use the data. So you have to control subject movement. That's another disadvantage of them. You have to control subject movement really, really well. So magnetometers work on the principle of radio transmission. One of the little discs is a transmitter, and the other little disc is the receiver. Now, any of you who have driven to Austin trying to keep your favorite radio station know that the further you are away from a transmitter, the weaker the signal is. Same kind of concept. When you breathe in, you expand the space between the magnetometers. Signal strength decreases, the voltage changes. When you breathe out, the signals are closer together, the transmitter and the receiver is closer together, the signal's stronger, and again, that's a voltage change. Okay, so all of these have the same principle. Movement induces a change in the voltage, and you have that voltage change related to some known volume of air. What's the disadvantage of a magnetometer compared to the respiratory inductive plethysmography?
It's only going to measure in the anterior and posterior dimensions.
Yep, it's only anterior posterior. So people who do kind of superhuman things like professionally trained Shakespearean actors or highly trained classical singers, you know they're going to be expanding in other dimensions besides just anterior posterior. So the magnetometer is used really, really commonly in our research. But remember, it's just an estimate. And most of the time, it's not as good an estimate as the RIP vest would be, or the Respitrace. Question. So those are the two main measuring devices that we use when we're trying not to attach a mask to the airway. And it's possible to go ahead and get measures directly. When I did my dissertation, I studied cheerleaders. And I looked at cheerleaders who developed voice problems and cheerleaders who didn't. And we had a spirometer. And I hooked them up to the spirometer with a mask, and I asked them to do their cheering moves. And using that direct measure of lung volume, I looked at how much they breathed in compared to their vital capacity. So it's possible to do it, but I got them all used to wearing it before. I made sure that they weren't, really altering their breathing a lot. But most people now would prefer indirect estimates of lung volume to actually attaching somebody to this. Okay? All right, so let's talk about subglottal pressure. Some people prefer to call this tracheal pressure. People who are really picky about semantics, because the glottis is open and you don't build up pressure when the glottis is open. Everyone in the world calls it subglottal pressure. Subglottal pressure is the pressure that's built up below the vocal folds when they're closed. And it is relatively constant once we start talking. So even though the vocal folds are opening and closing, it can really only be measured when the vocal folds are closed. And we know that it directly relates to how loud somebody is. So the bigger the subglottal pressure, the louder the person's going to be. For conversational speech, when you're just sitting in a quiet place talking to someone, your subglottal pressure as you're just speaking conversationally is probably about 5 centimeters of water. Okay, it's not something you'll really feel, not something that seems very effortful. If I'm up here talking to you, you're all relatively quiet, I'm probably generating around 10 centimeters of water pressure. If you guys were all talking and I needed to talk over you, it'd probably go to 15 or 20. The biggest subglottal pressures that have been estimated are, again, as you would expect, of opera singers who are on stage trying to sing over an orchestra. And they can generate subglottal pressures of up to 80 centimeters of water pressure. So that's huge. But you need that to have the sound carry. There are a few ways to measure subglottal pressure. The one that is used the least is the most accurate. There is only one way to directly measure subglottal pressure, and that's to somehow get a pressure sensing catheter right below the vocal folds. It isn't pretty. So it takes a tracheal puncture. That was a great face. It's all right. Nobody wants to do a tracheal puncture. So the way the tracheal puncture is done is somebody that you have great, great faith and trust in, who is a highly trained physician, will have a hollow needle, and a very, very tiny hollow needle, that he or she will insert right below the vocal folds, right about here. And then once that is inserted into the trachea, a tiny pressure sensing tube will be placed there, so it's perpendicular, goes in just like this. The faces you guys are making are great. Okay, I don't recommend that any of you become ENTs. And then the catheter, that pressure sensing tube, is connected to a pressure transducer. Okay, you've already calibrated the pressure transducer, and then you have the person do a variety of tasks. I did this once because I always believe in a study that I should do what I have my subjects do, so I actually had a tracheal puncture once. And I would not recommend it ever again to anybody because it makes you cough like crazy. It's terrible. If you have any sensitivity in the laryngeal area, you'll cough like you're going nuts. And it's a fair amount of pressure actually to get through the tracheal wall. It's not something that happens easily. Well, it was a guy I collaborated with. He was a brilliant physician. You know, truly, I would trust him with anything. And we did laryngeal EMG research where he'd put hook wire electrodes into different muscles of the laryngeal system. So, I mean, he could do all kinds of stuff. But I wouldn't recommend it. So it's really hard to get people to agree to having their subglottal pressure measured directly, especially like highly trained singers and actors, the people you're really interested in who do these superhuman things. So we need some indirect ways to do that. And what we're leading to here isn't necessarily how to estimate subglottal pressure in these superhuman performers, but what we're trying to do is get at a clinical use, which is trying to figure out whether the person has the ability to generate enough subglottal pressure for speech. Because sometimes you'll be working with someone and they'll sound kind of like this, and you don't know if the problem's in the respiratory system or in the laryngeal system. Okay, if somebody's breathy and they've got a weak voice and they're producing short phrases, you can't tell if it's because they can't breathe in enough air and generate enough subglottal pressure, or if really they can breathe in enough air and that's fine, but they're not able to close their vocal folds completely. So one way to do this, to see if they can generate enough subglottal pressure for speech, is with a leak tube manometer. Whoops. This is just a U-tube manometer with a vent or a leak right here. And you have the person blow into it. Now, because of the leak, they're not going to blow the water right out of it. Okay, the leak is venting air, so you can have them generate continuous pressure without continually displacing the water. Okay, some places have this. If you work in a facility that has a U-tube manometer, it's easy to put a little stopcock valve on it to get the leak, and you just have them displace one end of or one column of the water 2.5 centimeters because you double the displacement. Okay, if they do 2.5 on one side, they're displacing 5 centimeters of water, and you know they have the ability to generate that much subglottal pressure. Okay, that one's the tricky way to do it. We're going to do the easy way. So ages ago, this was in the 80s, the guy who's done the most research on speech breathing is Tom Hickson, and he's getting ready to retire at this point. But he came up with all kinds of really good speech breathing studies and some good clinical tools. One of the things that people have sort of come up with clinically is if a person is able to generate 5 centimeters of water pressure for 5 seconds, they have enough subglottal pressure for speech. So if you have somebody and you say, okay, you have to present this well clinically. Say, I'm going to have you blow bubbles for a while. It's to see if you've got enough driving pressure to get your vocal folds going for talking. And if they can generate 5 centimeters of water pressure for 5 seconds, then you can rule out a respiratory problem. Then you go, okay, what I'm hearing is not because of the respiratory system. And then if they have that soft, breathy voice, that the phrases are short, you go, okay, it's more of a laryngeal problem. They've really got enough air to work with. They can generate enough pressure to work with. Is that making sense? A lot of medical stuff is based on ruling things out. And this is a strategy that will help you rule out a respiratory problem with a client who sounds breathy and weak. So when Hickson published this, he titled it something like an around-the-house tool for estimating subglottal pressure, because you're never going to have the ability to measure it directly. So what I'd like you to do is I will show you how we're going to do this. And it's a little bit unwieldy. If there's only one ruler at your table, I would recommend using 1 bottle of water and putting your own straw in when you have a chance to do it. Okay? So the first thing you're going to do is make sure that your bottle of water has a little bit of space on top to blow bubbles. And if you hold the ruler up to it, you're at an easy measuring point. For most bottles of water, if you have the ruler flush with the bottom of the bottle, go for about 15 centimeters. Okay, and that's a nice, easy point. Remember, this side's inches, this is centimeters. And I'm going to drink mine to get it down to 15 centimeters. And I will hope I didn't drink too much. Oh, that's pretty good. Okay, so you want, guys, don't start talking now because I have to be able to explain it. So you want to make the top of the water at a point that's easy to measure. And once you have that point established, you're going to secure the ruler to it with the rubber band. So we're going to do this in a couple of conditions. The first one we're going to generate is the 5 centimeters of water. So go ahead and get the ruler attached. Drink quickly. And it really doesn't matter what shape the bottle of water is. Straight ones seem to be easier for the ruler. We used to do this with glasses, but you'd start blowing bubbles and the water was all over the place. So I'm hoping these are going to be deep enough. All right, everybody, yeah. You don't have rubber bands.
We have like 3 over here.
We've got a bunch more rubber bands.
Does it matter if you drank too much?
As long as you have a point of measurement, you'll be okay. I wouldn't drink too much because you want at least 15 centimeters of water in the bottle. Okay? All right, quiet, guys. So now, yeah, mine has a label on it right where I want it. Take the label off the water. Because you have to see where the straw is going to go into it. Okay, if you have the ruler, if you have the top of the water aligned with the 15 centimeter mark, you're going to put the straw in to 10 centimeters. Okay, so that's going to be 5 centimeters of water pressure. Okay, remember, water pressure is measured really, really literally. So 5 centimeters of water pressure means if the top of my water line is at 15, I go down to 10, that represents 5 centimeters of water. You can paper clip this on. Honestly, I think it's easier just to hold this in place, and you're going to blow for 5 seconds. Okay, so if you're sharing the bottle, don't share your straws. Don't blow hard enough that you end up with water everywhere. And what I want you to get a feel for is how much effort did that take? Okay, so go ahead and blow for 5 seconds at 5 centimeters of water pressure. Okay, and you feel that's pretty minimal effort. If your client can do that, that's all they need to produce speech. Okay, 5 centimeters of water pressure for 5 seconds will give you a functional voice if everything else is okay. Now, if your client is someone who has more speaking demands than that, let's say they need to talk loud, what centimeter of water level would I put it at? 10. You want to now displace 10 centimeters of water. I was just ready to say, someone promised me there wouldn't be math. You need now to take that 15, whatever you're lined up to, subtract 10 from it. So I'm going to now put my straw at 5 centimeters. Okay, so now you blow for at the 10 centimeter of water level. Quiet, guys. So now to me that feels more effortful. You can actually feel that it takes a bit of energy to do the 10 centimeters of water pressure. So you may have clients who can have a functional voice for quiet situations, talking really close one-to-one, but if they need to get loud, they don't have enough respiratory effort. Okay? Go ahead and do this at home. The other things that you can look at that are a little bit tricky are differences between P and B, like voiced and unvoiced sounds. B, b. That's a little bit harder. You typically generate less pressure with a voiced sound than a voiceless one. But people make fun of that when they see it outside our field. But it's a really easy strategy to help you differentially diagnose what's contributing to your patient's problem when they have that weak, soft, breathy voice and you wonder whether they've got the air they need. Yeah?
With a weak, soft, breathy voice, it's probably wrong. Its actual pitch give you a clue as well. So if you had somebody who talked really, really soft and always...
No, I think it's best usually to focus on one parameter at a time. So you really want to focus on intensity. And you know that there's a direct relationship between subglottal pressure and intensity. Pitch, you can have high subglottal pressure, low subglottal pressure, and still produce the same pitch. So it's not going to be as telling as focusing on subglottal pressure and loudness. Other questions? At some point, pass the rulers up. Don't spill the water, you know. Yeah.
Can that also be that breathy? Could that be behavioral?
Oh, well? You bet. Are you pressing the thing?
Yeah. She is. Okay.
Get to your job. So the question is, can a breathy voice be behavioral? Oh, yeah. We all know people who do that. Marilyn Monroe was the classic. We'll hear lots of different types of voice qualities when we get to the laryngeal system. But it can be, as actors say, a choice that the person makes in terms of how to portray themselves. Yeah.
I have a cousin who had a brain injury, and she has the very breathy voice and everything, but whenever she gets angry, she can yell just fine.
Yep.
Is it because she builds up more pressure in there?
Typically, after a head injury, one of the things that is missing is drive, getting yourself to do something extreme. If the person is really angry, you've got adrenaline kicking in, you've got an activation of all the muscle forces, finally the vocal folds close and they can be loud. But if they're not emotionally motivated to do so, they'll have a really weak, breathy voice.
Another thing that I noticed with her is whenever she's sedated, she also speaks normal, like completely normal, like before her accident.
That one I can't touch. Don't understand that. There are people after a head injury who respond very differently to pharmaceutical intervention than you would expect them to. So maybe sedation has a different effect on her. You know, the system is so screwed up after that. It's really hard to tell it's hard to predict how someone will react to certain things. Other questions? Okay, so let's talk about some differences in breathing for speech versus breathing for ventilation or just kind of staying alive. If you'd go ahead and flip to the slide, please. So here's a typical pattern. Remember, for most of our purposes, inspiration is up, expiration's down, inspiration up, expiration is down. So, oh, you're having issues?
Maybe we should.
So you're not seeing it?
No, it's just wiggly.
It's wiggly. Wiggly is ugly.
It's uninspirational.
Well, people have it in their notes, you know, if they print it out, so I don't think it's that critical. Oh, yes. Well, I'll have migraines at the end. So what is missing from this depiction of breathing? What maneuver is not here? The vital capacity maneuver. Okay, so you don't see any giant inspiration and a giant expiration. Now, if we were doing this for real, and we wanted to reference these lung values to a percent of vital capacity, we'd have to have a vital capacity maneuver on this same chart. Notice resting expiratory level is in a perfect spot, 38% of vital capacity. Okay, so here we have percent of vital capacity, 0% vital capacity is here, 100% vital capacity is here. So let's talk about some things that you notice. If you just look at inspiration, here the person's breathing quietly, here they breathe in for talking, and here they start talking. They breathe in again to talk some more. They talk. They breathe in for talking and they talk, and then they go back to quiet breathing. What's one thing that you notice about inspiration for speech versus quiet breathing? Go ahead.
You don't always come back to the resting level?
Yeah, I guess I would think of that more on the expiratory end of things. Just focus on the inspiratory limbs for now. I should have started with expiration, obviously. Go ahead.
It's more abrupt. Like
yeah, it's so I find it a little bit hard to see, but most people believe that inspiration for speech is quicker. When you're breathing quietly, you have relatively equal inspiration and expiration. When you're breathing for speech, we do everything to maximize our ability to get into a conversation quickly. So we tend to breathe in quicker. What else do you notice about inspiration for speech compared to quiet breathing? The most obvious one.
We take a deeper breath.
Yeah, it's a bigger breath. Now ballpark, and this is useful for when you're clinicians. Ballpark is twice tidal inspiration. You want to breathe in about twice as much for talking as you do for quiet breathing. That's referred to as twice tidal inspiration. Tidal breathing is just you breathing quietly. You need about twice as much air to talk on. And that's ideal. Remember we said, really honestly and truly, you could breathe on tidal volume. I mean, you could speak on tidal volume and you'd be okay. But if you want it to be a little less effortful, most people will breathe into twice tidal volume. Now the big differences you see here are in expiration. And what do you notice in the expiratory limbs between quiet breathing versus speech? Go ahead. This is what you wanted to say before, right?
It's gradual. It's going in a diagonal.
And controlled. Okay, so clearly the expiration is controlled. And controlling the expiration does what to it? Compared to quiet tidal breathing. Yeah.
Makes it longer.
Yeah, it's longer. Okay. So we've got a prolonged expiration for speech. We're talking on our air. We're controlling it so we don't waste all our air. We need something to talk on. The thing that you might notice about this that's unique is when this person is talking, do they ever go below resting expiratory level? No. So what muscles are they using for speech? This is jumping a little bit ahead. What muscles are they using for speech? Go ahead.
Inspiratory.
Inspiratory muscles. Because they never go below resting expiratory level. They never force the system into expiratory reserve volume. That's where they'd need the expiratory muscles to kick in. Okay, so in this sort of idealized, perfect way to talk, they always stay above resting expiratory level. They always breathe into at least twice tidal inspiration. So this is kind of a perfect schematic of what people do. How often do you think people actually breathe like this? Yeah, like hardly ever. You know, people who know they're in speech breathing studies will breathe like this. Everyone else on the planet breathes all over the place. And it works fine, unless you have compromise in the system somewhere. Otherwise, you can get away with it. So let's look at a couple of specifics. If you have this chart in front of you, what we're going to do is fill out some differences between breathing for speech and breathing for ventilation. The first thing we're going to address is location of the air intake. Where do you breathe in? If you're just breathing quietly, assuming you don't have that cold and laryngitis that's going around, if you're just sitting there quietly, for quiet breathing, where do you breathe in? Through your nose. Okay, so quiet breathing is almost always through your nose, unless you're a, quote, mouth breather, and usually there's a reason for that, like allergies or a cold or congestion somewhere. When you're breathing for speech, where do you breathe in? Somebody hit the mic and tell me.
Oral.
Mouth. Yep, you breathe in through your mouth. Why? What's the main reason we breathe in? Okay, let's back up. What's the main reason we breathe in through our nose for quiet breathing? Go ahead.
Because our mouth is closed.
Okay, but what's the advantage of breathing in through our nose? What does it do for you? Go ahead.
Filtration.
Filtration. I'm sure there's some other way to put it. It filters the air. What else does it do?
It warms the air at the same time.
Warms it up. Usually not a big issue in Houston, but in this room, warm air is a good thing. Okay, so the two main things that breathing through the nose do for you is it cleans the air, filters, all those little nose hairs have a purpose. It cleans the air and it warms the air. But, you know, we give up on a lot of advantages when we decide to breathe for speech. What's one of the reasons that we breathe through our mouth for talking? The main reason. Go ahead.
To get more air in quicker?
To get more air in quicker. Yep. And what physically allows us to get more air in quicker through our mouth? Go ahead.
The size of your oral cavity is bigger than the size of your nasal cavity.
Yep, the oral cavity is bigger, it's less obstructed. So overall, there's less resistance. Always think about resistance and efficiency. There's much less resistance to air going in the mouth than there is to the nose. All that filtering and warming action comes at a cost of high resistance. We don't care about that when we're just breathing quietly. We don't want any resistance to airflow when we're trying to jump into a conversation. So we breathe through our mouth because it's quicker, it's more efficient, less resistance. So we can breathe in bigger and faster through our mouth. Okay, what about the frequency of breathing? About how often, how many breaths do we take just breathing quietly? Anybody know sort of a typical? For most people, it's about 12 breaths per minute. Now, I'm sure if you start counting it and being aware of your breath, you'll screw it all up. But most people say it's roughly about 12. And 10 to 20 is sort of the range that you would expect. What are the breaths in speech breathing characterized by in terms of frequency? You're going for less frequent. I don't know that I go in one direction or another. Think about a regular old conversation where hopefully you're letting the other person talk sometime, and then you talk sometime, and you say uh-huh, and then you say something longer. Is there any set characterization of the frequency of breaths for speech breathing? No, it's really variable. It depends on the circumstances, depends on who you're talking to, depends on how much you want to say on one breath. So the best characterization is that it's irregular and variable. And you're right, most of the time it would be less. Most of the time it's going to be less than 12 breaths per minute. Especially if you're doing some kind of monologue thing. Okay, so here we have a lung volume comparison. And again, this is sort of idealized. Is this next in your thing? That's not next on my notes. Tidal volume typically takes about, here's where we start referencing to vital capacity. Tidal volume, typically you use about 10% of your vital capacity. So let's say a woman has a 3,000 cc or 3 liter vital capacity. Her quiet breathing is going to be about 300 cc's. Most guys have around 5,000 cc's or 5 liters. Their tidal breathing is going to be around 500 cc's. Okay? Just so you get a ballpark. You don't need to know it. Most of the time when we're breathing for speech, because it's twice tidal inspiration, Most of the time we're going to breathe in a volume that is about 20% of our vital capacity. So think about how huge our vital capacity is. Does 20% seem like much? That's not a lot of air. It's really not. And it can certainly vary. You know, if somebody's talking louder, they're going to breathe in more air. One of the big things that's involved in all kinds of training for professional voice users is how you manage your air. And one of the big things is having you breathe in more than usual so that you're not relying on laryngeal muscle tension to be loud, but you've got lots of air to support your voice. Now, one of the things that we do throughout speech production is we really try not to work very hard at it. And in order to not work hard at speech breathing, when we're talking, we stay around the middle range of our lung volumes. So on this perfect one that we had here, you can see we're right around the middle of our vital capacity curve. So this person is talking from about REL to maybe about 55% of their vital capacity. What's the advantage of staying in that range? Why does that relate to the principle of least effort? Go ahead.
Because, I don't know if I can explain this very well, but you don't have to use like extra exhalatory muscles to keep talking, and you don't have to use extra inhalatory muscles to keep the air up in there. So basically, if you stay around REL, you don't have to use any extra muscles.
Yeah, exactly. So most of the time, if you vary around resting expiratory level, most of the time you have minimal use of those active forces to counteract the relaxation forces. The relaxation forces, if you stay around REL, are not huge. It's not like you breathed in as much as you possibly could and then tried to control it for talking. It's not like you're going way, way below resting expiratory level and have to keep pushing the system down there. If you stay within that mid-range of lung volumes, it doesn't take a lot of extra work to control your breathing for speech. Does that make sense? That's where you have to picture the active forces counteracting the passive relaxation forces. And you don't want to use those muscles all that much. So, you know, especially in conversational speech, you should be staying around that mid-range of lung volumes. Okay, in terms of the ratio of inspiratory to expiratory time, how much time we spend breathing in compared to breathing out. For quiet breathing, you can think of it as kind of 50-50. Technically, expiration is just a little bit longer in quiet breathing. It's more like 40-60, but only respiratory geeks really care about that. So it's roughly even. For speech breathing, about 10% of respiration is inspiration, and about 90% is expiration. So we really alter that 50-50 relationship when we're breathing for speech. So we breathe in quick and then we extend it. Go ahead.
Can you just repeat that?
Sure. For quiet breathing, the relation between inspiration and expiration is about 1-to-1, 50-50, about half the time breathing in, half the time breathing out. In breathing for speech, when you look at a cycle of respiration for speech, about 10% of that is breathing in and about 90% is breathing out. So we spend a lot more time on expiration for speech. Yeah.
In anatomy, I remember learning that quiet breathing was 60-40.
It is. And so if you want to be really precise, you go 60-40, and if you want ballpark, you go, yeah, it's kind of 50-50. Because there's a little bit more checking action on the expiratory limb of breathing out. So that's the 60% part. So that will always be correct if it ever comes up. But I don't think it will. Okay, so what you want are the big global comparisons between speech breathing and quiet breathing. Okay, let's talk briefly about muscle activity just during expiration. Okay, muscle activity for breathing out when you're just sitting here breathing quietly. What's active for expiration? This is almost a trick question. It's as close as I'll ever come to a trick question. What muscles are active? Go ahead.
No muscles.
No muscles. Right. You just relax. Breathing out's really, really easy for quiet breathing. You just relax. Everything goes back to REL. Speech breathing, on the other hand, now you got to control the expiration. When you're above REL, what muscle forces are you going to use to control expiration? Inspiratory. Good. Because you're counteracting passive relaxation forces. Okay, so we've got a typical breathing pattern for speech. We breathe in quickly. If you are an efficient talker, pretty much at peak inspiration, you're going to start talking. You don't want to waste a lot of air there. Okay, so the timing of when you start talking compared to when you breathe in matters for efficiency. People who have muscles that move slowly, or their vocal folds close slowly, tend to waste a lot of air right at that peak where you transition from breathing in to beginning to exhale for speech. So very shortly after expiration begins, you begin to talk, and you tend to breathe in for longer utterances and louder utterances. You breathe in more. Any questions on the basic pattern for breathing? Got the differences down? Okay. There was a classic study. I love these guys' names. Draper, Latifogan, and Witterich. Doesn't it sound like a law firm? They were at USC, and they studied breathing, and they were one of the first people to study breathing using EMG and getting estimates of esophageal pressure, which is another way to indirectly get at subglottal pressure. So they didn't stick a sensing tube in the person's trachea. They had them swallow an esophageal balloon. Yeah, I don't know which is worse. They had them swallow an esophageal balloon, and then the little esophageal balloon was connected to a pressure transducer. And that gave them an estimate of subglottal pressure that way. Now, the key thing that Draper, Latifogan, and Witterich said was the only time that we used expiratory muscles was below resting expiratory level. And that's pretty much what we've been saying, right? They kick in if you want to be one of these people who talk and talk and talk on one breath, and you go below resting expiratory level. And so for years and years, that's what people believed. I mean, when I was in grad school, people still believed this. Hickson is the god of speech breathing, and Weismer is a guy he would probably like to be called a god too. He's at University of Wisconsin and does a lot of good work in physiology. And they said that Draper, Latifogan, and Witterich really didn't analyze their data right. And so they got all of their original data, and they reanalyzed it. And they contended that you really can't have complete abdominal relaxation and have the expiratory muscles only kick in below resting expiratory level. They said it really, really just won't work. And the reason they said it won't work is if your abdominal muscles were completely relaxed and you breathe in, the diaphragm doesn't have anything to contract against. And the only analogy that I've ever been able to think of is because I'm a Yankee and I can picture frozen water. The only analogy that I can think of is if you're on a frozen lake that's really, really deep, and you go through, and you think that, okay, I broke through, the ice shouldn't be all that thick, and you move and you try to push your way up through the ice again. If you don't have any foundation like the bottom of the lake below you, you can't exert any force. If you fall through in a shallow part of the lake, and you've got the bottom of the lake below you, you can exert tons of force. So it's like trying to push against a moving thing or trying to push against a solid object. You can generate tons more force when you push against something solid and firm. So Hickson and Weismer said that in order for the diaphragm to contract really quickly and really well, again, thinking of efficiency, you need a little bit of abdominal muscle contraction. Again, this is for breathing for speech, not for quiet breathing, because we all let our tummy pooch out when we breathe quietly. Breathing for speech, we need a little bit of tension here so that the diaphragm has something harder to contract against. Is that making sense? So if you keep your abs a little bit tighter, again, this goes back to all those vague things that singing teachers say, use abdominal support, use breast support. Part of what they're talking about is to keep the chest wall a little bit tight, especially the abs, so that you've got something for the diaphragm to contract against and you can do it more efficiently. Questions on that concept? We're going to stop there because what I want you to do is think about that till we come back next time and see what questions you have, and then we'll pick up from there and go into breathing across the lifespan. Okay? Do you guys need new slides? Yeah. Lifespan isn't there? Okay, so I'll post new slides when I get back to the office. Okay? Have a good afternoon, guys.